Good afternoon, everyone. Hope you can all hear me clearly. I'd like to welcome you all to this event, which has been organised by the Global Health Working Group of BISA and the British International Studies Association, and Global Health Europe. And I'd like to begin by expressing our thanks to the Centre for Global Health Policy at Sussex University and to the Health Protection Agency for co-sponsoring this event, and to the European Commission representation in London for hosting a meeting here at Europe House. I'd also like to thank Sonia Kettleson and Alexia Dutton, who provided two interesting background papers for this meeting, which we've all received by email. Before I hand over to John Wynne Owen, who is going to chair today's meeting, I'd just like to say a few words about the background and the context in which today's discussions are taking place. We will be discussing how current economic conditions are creating an opportunity for a rethink of Europe's approaches to global health. And perhaps a good place to begin is just to reflect on what we mean by the term global health. And in fact, the term is used in many different ways by different people. The way we use it in Global Health Europe is to refer to factors transcending national boundaries and governments, and that determine, therefore, the health and human security of people around the world. This involves a number of elements, and in the area of health security, there are challenges such as threats from infectious diseases, pandemics and biohazards. It also includes aspects of non-communicable diseases and a whole range of determinants of health, many of which are subject to the forces of globalization. It also includes health diplomacy, and this has become an increasingly important field alongside science diplomacy in recent years. And a recent meeting held by the Royal Society noted that there are a number of different strands within science diplomacy, and I think the same applies across the health diplomacy field. And global health also includes aspects of the broader concern for health equity, which we see in current debates such as how to ensure the creation of affordable and accessible global public goods, such as medicines, and the current drive towards universal health coverage. The second thing that I want to highlight is that Europe is a significant player in global health. So, although the provision of healthcare is a matter for each individual country, the Maastricht Treaty established that there is an important role for European community institutions in relation to health protection policies and activities. The Lisbon Treaty strengthened the legal basis for this, and in 2010 the role of the EU in global health was explicitly set out in the communication from the European Commission. And in addition to broad European coverage of global health, there is also important work done by individual countries, and in this context I'd just like to highlight an important example of the UK position set out in the government's global health strategy document, Health is Global. The context of today's meeting is the challenging financial situation in which Europe finds itself. And I'd like to point very briefly to two aspects of this financial context. First of all, there is the current Eurozone crisis. The global banking crisis, which surfaced in 2008, has had an immediate and profound effect on the world's economies. And within the advanced economies, the Eurozone and related economies have been very badly hit, with growth generally stagnant or negative, and many countries undertaking deep cuts in areas like health, social protection, and international development. But the immediate Eurozone crisis also needs to be seen in the context of a major longer-term shift in the world economic order. A few years ago, it was predicted that the combined GDP of the so-called developing and emerging economies would overtake the combined GDP of the so-called advanced economies by 2013. This shift in the world order is well underway, and in 2010, China, which was then the world's largest exporter, overtook Japan as the world's second biggest economy. In 2011, India overtook Japan to become the world's third largest economy. According to an IMF prediction made in 2010, by 2020, every one of the largest so-called advanced economies, with the exception of Canada, will have moved down the GDP league table, while every one of the largest so-called emerging economies will have moved up the table. Given this background, it's not enough simply to view the Eurozone crisis as a short-term threat to Europe's position regarding global health. The economic power in the world is shifting east and south, and with it comes the power to influence global policies. So we need to regard the current hiatus as an opportunity and ask questions about how Europe can reposition itself to take advantage of the shifting scene, and how it can realign itself to gain greater coherence between policies, strategies and practices, while preserving and promoting values that Europe has cherished, such as equity, fairness and inclusion. And time is pressing. Over the course of the current decade, many important issues relevant to global health and Europe are arising. And just to mention four of these finally, in April this year, the WHO Consultative Expert Working Group on Research and Development, Financing and Coordination issued its report, which was discussed at the World Health Assembly in May. As a follow-on, WHO is organising an open-ended meeting of member states in November to discuss the report's findings, which included recommendations for a global R&D convention that will cover financing, coordination, and the creation of a global health observatory function. The process is currently underway in Brussels for the creation of the successor to Framework Programme 7, which is one of the largest research programmes in the world, spending currently over 55 billion euros over 7 years. And a good slice of this is on research, development and innovation for health. The proposed budget for Framework Programme 8, which will be known as Horizon 2020, is about 85 billion euros, and health is one of a half a dozen areas specifically designated for attention. There are big issues currently being debated about how the new programme will foster innovation in health in the European Union, and the extent to which it will address global health issues. The process is also underway for considering what will follow the Millennium Development Goals after 2015. Collectively, the European Union is the largest provider of development assistance in the world, and the European Union has recently funded an international research programme aiming to provide an evidence-based set of options for the post-2015 development goals. Individually, the UK is intimately involved in the process, with Prime Minister David Cameron chairing a high-level UN group that is preparing for the UN meeting in 2015. Much of the global debate is now centred on incorporating global health within a broader set of sustainable development goals. And during the course of the current decade, the EU is pursuing its growth strategy, Europe 2020. To meet the Europe 2020 targets, there are a series of flagship initiatives, one of which is the Innovation Union, which aims to refocus research, development and innovation policy on major challenges while closing the gap between science and the market to turn inventions into products. So it's against this background that we felt that it's an appropriate time to talk about global health and the Eurozone crisis, and I'd now like to hand over to John and Owen, who will chair today's discussions.
I probably got a loud enough voice for you to hear me without this microphone. But can I add my welcome and also my appreciation to those who've been involved in planning today's meeting, and also to people who are going to be speaking, and also hopefully keeping a record and making it available to the wider community, as well as encouraging those who've written background papers to format them in such a way that they can be published. I'm particularly pleased as the chairman of the Global Health Committee of the Health Protection Agency to be one of the sponsors of this meeting, because it very much fits with the Health Protection Agency's global health strategy, which formed an important part of Her Majesty's government's Health is Global. And as part of that strategy, the Health Protection Agency was given new money to contribute to increasing UK and global health security. And we were given funds to do more work internationally to influence decision-making in international public health networks. So today this is an important opportunity, as well as contributing to the global research initiative. The funding for our initial tranche of money also was a contribution to setting up what was called then the European Council for Global Health, which we might now call Global Health Europe, and that was funded to increase the European voice in global health governance and to be a powerful advocate for a sustainable European commitment to global health. Every Welshman has to have a text and at least one or two headings within that. And I'm going to take my text from a speech that Margaret Chan gave in Brussels at a time when she was speaking on advancing European health amidst global crisis. Our world is dangerously out of balance. This is clearly an unhealthy condition for people, but also for economic prospects, for world stability and for security. She went on to say that a market-based economy is still the best way to lift people out of poverty and to improve their health status. And she cited Brazil, India and China. But then she went on to say market forces do not solve social problems. And equally important is a statement by the executive chairman of the World Economic Forum in Davos, who said, greater social equality must become the new economic and social imperative for a stable and a secure world. At our Health Protection Agency conference in Warwick a couple of weeks ago, the director of the Cabinet Civil Contingency Unit gave us an insight into some of the thinking in the session that we actually had on public health emergencies, and in a way it reflects having seen the Olympics served safely in London. The government is now looking at what are some of the big emerging risks. And in her session, she said that as part of cross-government preparedness, response and resilience, she highlighted some of the big issues, which included economic downturn, Eurozone, and the domestic consequences of civil disruption, industrial action, and the priority to build community resilience. Equally, given that we're sitting in this building in the United Kingdom, our sort of ambivalent relationship with Europe is actually quite an important feature of what and how some of the debates might be taken forward in London in the European and global context. And Philip Stevens, writing in the Financial Times last week, said that British foreign policy should be realistic, not romantic, and should start from first principles, that the national interest lies in an open world economy and in access to international trade and investment as an important contribution and a stake in global security, and that we needed a twin relationship with Europe and the United States, and a recognition that the European Union can be an influence multiplier, and that too often the Cameron government too often hankers after a new Elizabethan age, leaving the troubles of Europe behind to make fortunes in far-off lands. Sad to say, he says, romanticism is eclipsing realism. The first step towards serious foreign policy is to see the world as it is, rather than as one might like it to be. And equally, picking up the theme that Stephen mentioned on global economic front, the outgoing president of the World Bank said in his summary about the new age of globalization that the balance of power has shifted, with developing countries now the engines of global growth, and they're desiring to be stewards of their own futures. And further, the old notion of rich countries funding development in poor countries is no longer appropriate, as emerging markets rise in economic clout and are as much sources of development cash as they are recipients. And equally, the new incoming president of the World Bank has recognized that some of these issues are their priorities. So today's meeting is going to give us an opportunity to look at Europe for global health and global health for Europe. Just as I hand over to Andrew Jack, who is going to moderate and chair the sessions, I'd just like to say that in the Financial Times in August, he wrote, particularly around the global health policy, that the need for radical answers for tough times required the need for more efficiency and innovation. So Andrew, I hand over to you.
Thanks very much, John. And welcome. It's a pleasure to be here on behalf of the FT. And it's also great, obviously, since we're talking about Europe and global health, couldn't be a better venue, of course, to be hosting this meeting, even if perhaps it would be nice to see some more European officials here to kind of engage in this debate, but perhaps we'll hear a little bit more also from the audience on that. No text from me, but it's fitting to go after John, because of course the HPA has played a very important role within the UK, but also internationally. And one only has to think of the last few days and coronavirus appearing, unknown infections from the Middle East, the E. coli scare, of course, only a few months ago, to remind ourselves of how global infectious disease threats are and how much they don't respect boundaries. Therefore, the self-interest on the one side, perhaps, of the need for that global activity. And on the other, again, an example, of course, from the HPA, which was very instrumental, drawing partly on its work in the UK, on the development and rollout of an extraordinary new meningitis vaccine in Africa. So again, a reminder of what Europe can give also to the world, building on its own expertise. So anyway, we've got two sessions this afternoon. The first, Europe for global health, essentially around the question, what should Europe be doing in this field? We'll have three speakers to give short presentations, and then very keen to open this up for interactive discussion with everyone. And then a second session later afternoon, more on global health for Europe, switching the question round. So let me ask perhaps first our first speaker to come up and make some introductory remarks, Nick Tomlinson, Head of International Affairs at the Department of Health. Thanks.
If I could interrupt 1 second, I forgot to say one thing to everybody. You may have noticed the little video camera there. We are videoing this meeting. If anybody objects to being on the video, let us know and we will delete you when they meeting. Otherwise it will be very constant.
I should have my hair this morning.
Thanks, Andrew. I think probably first go back a few years now, and Stephen mentioned earlier the Health is Global strategy the government at the time published back in 2008. And that was really, I think, very much a world first. It was the first time that any country had really looked across all of government and said, what contribution can each government department bring to the global health agenda? So for the first time, set out in a single document was what collectively UK government could bring to advancing the global health agenda. The reason for doing that were really, in some ways, quite evident. As Andrew mentioned, a key component of that is the fact that diseases don't respect national borders. And I'm reminded that on the bus over here this afternoon as I came past St Thomas's Hospital, recognising that one individual is in there with coronavirus at the present time. Beyond that, though, there's also the other dimension to this, well, two other dimensions. There's how UK can best contribute to developing health systems in developing countries, but also recognising that the world is changing. What is the trade dimension to global health? And again, how can the UK best position itself in that respect? course, if you moved on then a couple of years, we had a general election, a change of government, so if nothing other than cosmetic reasons, the fact we had the picture of the then Prime Minister in the inside cover, we reviewed that strategy. Actually, when we discussed this with ministers, that there was very much broad agreement with the principles behind that strategy, so that there was no real disagreement between all three parties, really. But what we also did at the time was take the opportunity to try and focus that strategy a little more. So there were, I forget now the exact number, in the order of 40 odd deliverables that have been identified that, whilst all very well intentioned, it was proving something of a challenge to actually keep track of all of those. The other dimension is in terms of what's happening in Europe as well. And in 2008, I'm sure that the dates are just accidental, that Europe published its health white paper, which set out what European member states collectively could do in the area of health generally. And in amongst that was a recognition that there was more that Europe could be doing in the area of global health, and how Europe could strengthen its voice in the global arena. That component moved forward then in 2010 with a set of council conclusions, really setting out how, actually for the first time, the Commission could work together. The Commission is notorious for working in silos, but here we had three different parts of the Commission coming together with an agreed position. So we had health, research and development, all with a common agenda in terms of taking forward the global health agenda. I think also if we then look at the global health strategy is very much, I say, across government strategies. If I then look at some of the areas that within the Department of Health we're taking forward, but by no means wanting to downplay other departments, but really just to give you a flavour of some of the activity we are taking forward. In the area of international development, we work very closely with DFID, initially with their Health Links scheme, which was encouraging collaboration between health providers in the UK and organisations, particularly in Africa and Southeast Asia. That has since moved forward under the Health Partnership Scheme. But an important component of that is the expertise that we have in the NHS and how we can make the best use of the technical skills and really the willingness of staff in the NHS to really make a difference to health, particularly in developing countries. So we see a considerable amount of volunteering at an individual level, but also at a hospital level. There are a number of planned collaborative projects, a number, for example, in Somalia, where it's really an opportunity to take individuals from the UK to work alongside health professionals in developing countries, but also to bring them over to the UK. And certainly all the feedback from that is very positive, that it is a very effective way of transferring information and experience. In terms of global health security, just to take one example, we now have 5 outcomes under the health security banner in the health outcomes framework. One of those being emergency preparedness. We've been working very closely with Brazil in the run-up to the London Olympics, but it's an ongoing program of work given that in 4 years' time they will be hosting the Olympics in Rio. So it's sharing the lessons we've learnt in London so that they're well prepared as well. Brazil is perhaps a good example of some of the other activity we've taken forward. We're working now with a number of emerging powers. We signed a memorandum of understanding with Brazil in April last year, which I think has really gone from strength to strength over that last year, looking at how we can collaborate in a number of areas. Yes, inevitably there is a trade dimension in the longer term to that, but that's not the main focus. The main focus is how can we learn from each other. So, for example, Brazil has made great strides towards the introduction of universal health care. It has challenges that I don't think we'll ever see in Europe, given that some of the remote rural areas that they're dealing with. So one of the things we're looking at is what can we learn from the Brazilian Health Partnership Scheme in the way that's operated? Are there any lessons that we could then apply to some remote areas in the UK? And on the back of that, we're setting up a pilot project in Wales, really very much looking to see how can we learn some of the lessons from Brazil. In terms of health and conflicts, well, it's still not the most stable country, but we're working closely with Libya, helping them to rebuild their health system. Very much recognising there that their health system is in a pretty poor state. There are very few hospitals, there's no ambulance service, for example. They clearly have a number of other challenges, but again it's an opportunity for all parts of government in the UK to come together. So there's clearly a lot of experience from the UK in how we operate the NHS. We're not suggesting they take the NHS and transfer it to Libya, but there are a lot of experience that we've learned that they can take into account as they develop their health system. India and China are again other countries we're working closely in helping them to strengthen their health systems. On the broader commercial front, we are working in the Gulf as well. That there is clearly a lot of money in the Gulf. They're equally looking to develop their health systems, and so there are opportunities for the UK to assist there on a more commercial basis. I think, coming back to the exam question we were set, what should Europe do for global health? To my mind, there are some opportunities there to bring together some of the initiatives that are happening in individual member states. So I talked earlier about some of the volunteering work in the UK, but really I think there's more scope there for making that more joined up across Europe. So we can really make a big difference in individual countries rather than having each country working in isolation. It's also something we're looking to try and do now with Brazil. We've in the Memorandum of Understanding, we talk about looking at the possibility of setting up some triangular collaborations. So how can we work with Brazil in African countries, for example? And I think the same opportunities are there in Europe as well. Another big challenge that is not restricted to Europe by any means is around non-communicable diseases. There are, that is, I think to my mind, one of the bigger challenges that we're going to see over the coming years is affecting not just countries in Europe, but it's having a big impact in developing countries as well. So again, it's how can we learn from each other, but there's also, I think, something about doing things at a larger scale. So for example, in the UK, we've been taking forward the responsibility deal, working with industry, looking at how, for example, we can encourage reformulation of products to reduce fat content of them. But you're going to have far more impact if a number of countries come together and say, this is what we're really looking for in terms of food formulation, for example. Another big challenge is around human resources for health. That is both a challenge within the EU, but it's clearly a much bigger challenge outside the EU. So again, I think there are opportunities there. How can we, as EU member states, really work together on the human resources for health agenda? And then perhaps if you look further afield within WHO, that's an organisation that's now been in existence since, well, in 1948. I think as an organisation it hasn't changed a great deal in that time, but current Director General Margaret Chan is very clear that it's an organisation that needs to be changed. One of the challenges there is really focusing the organisation on the issues that really matter. So again, there's a role for Europe amongst other players in really articulating what are the priorities looking forward. I think it was John, you mentioned the expert working group on research. It was interesting, I was at a meeting in Washington last week on the Pan American Health Organization, where it was very clear that on the one hand you had Brazil, the one protagonist, saying yes, there should be a binding commitment, on the other hand the US. By the end of that discussion, there seemed to be very much a recognition actually that the important thing is not whether it's a binding legal instrument or not, but that we actually get on and make some progress around research funding. maybe leave it at that.
Okay, thanks. Plenty of questions, but let's have our other speakers first, and then we'll go into a three-way discussion. Maybe Beatrice Nia, Programme Officer from the European Office against.
Good afternoon. First of all, thank you for inviting me. I'm really honored and very interested about this discussion. It's good that I'm speaking in Synod, because the more I hear speakers, the more I'm adding to my bits of paper, and I'm afraid I'm just going to be way too long. So I think, first of all, looking back at the definition of global health that was given earlier, I think it's clear that the Foundation has chosen to specialize in a few of those. So I'm excusing myself already for being narrower than the full description, just because my comments would not be as relevant otherwise. I think there are three ways we can look at what Europe can do for global health, and I think Nick has already expressed that in many different ways. There is what member states are doing themselves, there is what the EC is doing, and then what can be achieved when both work together. What it has done already in the past is that European countries have been the largest donors, both for ODA combined, but also for, more specifically for global health and key institutions that have been able to really leapfrog health progresses in developing countries, such as the Global Fund. European donors provide above 50% of the Global Fund's funding since its creation. Same for Gavi, over 60%, and over 90% for UNITAID. And that has been done via both political will as well as very smart financial innovation, as well as just a vision for what global health could be doing. And so the IFIB, the International Facility for Immunization, was created in 2006, with again leaders within Europe that otherwise would not have made this really smart tool possible, providing available funds right away for very important vaccines to be rolled out in Africa, and as well as providing a long-term, predictable, and flexible way to access those resources. Similarly, the advanced market commitments, and we're talking about markets, right? About the fact that it's not just about the right thing to do, but also the smart thing to do, but also showing that there is a market for those important health services in Africa. And so the AMC for pneumo vaccine in 2009 is another example of what Europe has done for global health. I'm not going to mention again the air ticket levy. I'm French, as you can hear, so I'm not in the same way you did. I'm not trying to praise the leadership of France in particular, but those examples come to my mind. European countries also have a very strong tradition of actually prioritizing social capital, including health, family planning, and other important priorities within their foreign aid investments. In terms of research, what is interesting is that while Europe has been the leader in ODA, actually when we look at health research, then the US is actually providing about 70% of total money for global health research, in spite of very strong technical expertise in Europe. We were talking about the UK, again I'll go on to France with the ANRS and the Institut Pasteur, but I think there is it's recognized that there is a gap here potentially. And then with the fiscal contraction coming up, that has happened already over the past 2 years, and other big tickets investment potential being threatened, those governments who should really be able to resist that temptation, understanding that the small percentage of investments cutting national budgets on that matter would have huge impact in cutting antiretrovirals, net vaccines, and other things that the again, talking from just an economic standpoint, the cost-benefit analysis is just absolutely clear. Moreover, it will also have a very damaging disincentive on the private sector, with whom we've been really trying very hard to bring into the picture for a sustainable long-term view of why those investments matter. So looking forward, what Europe could do for global health, there are two things, or three things actually in my mind. There is the obvious continuation of those really smart investments that really just represent a fraction of their overall budget. And the next 7 years budget of the multi-financial framework currently being negotiated in Brussels is a really important piece of that. And obviously right now the negotiations are such that the member states are really going to be the ones in negotiation obviously with the European Parliament able to choose whether the development aspect of that budget will stay intact or not, based on the proposition from the Commission. The health R&D piece is interesting because it's linked to growth, because actually if you look at the EU budget, it is within the Pillar 1 growth budget of the European Commission, and that there is a natural return on investments back into Europe to invest on R&D for developing countries, challenges specifically, and I think the EDCTP example initiative, which I'm just going to take as an example of what happens when the EC and member states really work together. This is this European and developing countries clinical trial partnership. So it's European research and African-based research working together on phase 1 and to phase 4 clinical trials on 3 diseases more specifically, but they're looking to expand that. So first on HIV, TB, and malaria, and it's being funded by the Commission, and then the Commission matching the contribution from member states. And that initiative has been absolutely critical and could really show, is looking to expand up to €1 billion over the next 7 years. That alongside, you were speaking about the human resources aspect and how some human resources in Europe can be helpful to systems in developing countries. There is also this ESTER initiative, which is the network of hospitals in various European countries, actually linking back to being, spending 6 months to a year, depending on the need in some African countries, and not only being there at the hospital level providing services, but also doing the ex ante and post visits. So really actually going into much more of the human resource question, reaching out to the community level, which to us the foundation is really critical, because one of the things we're trying to really nail is how we are going to get to the last mile of the person that is not really being reached by those services, typically, be it for health reasons or for other actual, in the field of health or agriculture. And finally, I'll close with the fact that triangular partnership, as you were saying, I think is something that Europe is uniquely positioned to do. I think Barroso, last time we met with him, was talking about, you had the political, monetary union, political union. He wanted to really create a European Union of innovation and knowledge. And the fact that, as you were saying, there are some lessons to be drawn from emerging countries that have just experienced this change and are being involved in Africa no matter what. And so how do we link those very smartly together so that Europe can play the role it really has the potential to. I'll stop here and I'll be excited to discuss further.
Thanks, Beatrice. So let's call now Chris Brooks, Director of Programmes and Partnership at Health Action Partnership International.
Thank you, Andrew, and thank you to Global Health Europe. I have done what I was asked to do, and that is answer the question, or that's what I'm going to attempt to do in the next 8 minutes. So what I'm really focusing on is what should Europe do for global health? And just so that you know who I am, why I'm here, and why I'm speaking, I come from Health Action Partnership International. We're a not-for-profit organisation. We grew out of work within the Department of Health. We focus particularly on equity and the underlying causes of health inequalities globally. So we emerged out of the work that was done by the Commission on Social Determinants of Health, Michael Marmot. What we are currently focusing on is really how can we share learning about what can improve health globally and identify ways of sharing that effectively. I'm not an expert in any particular health subject, but I attempt to bring together people who are experts in their particular field, and that's our strength. So we have to unpick the question a little bit. So what do we mean by Europe? And so far we've taken it in one major way, which I agree with, which is focusing on the European Union and the underlying member states behind that, which we all play a part in. But also just to remind us that we are also talking about WHO, the Regional Office for Europe, and we shouldn't forget the very strong leadership role they have across much of the Europe, which includes, and someone's going to correct me no doubt, I think it's now 53 countries, goes as far as Mongolia. It's a strange definition of Europe, you might say, but nonetheless that's the definition that WHO are using. And then also chose to define global health, which is ever so slightly different from Stephen's. It comes directly from the Commission communication from 2010, and you can read it there yourselves. I won't read it to you. When we were involved in the social determinants of health work, I thought that Gordon Brown very usefully said that we need to, the economic crisis that was occurring then and this slow car crash time, I think we can safely say, now, is a reason to continue to work together and can't be used as an excuse. And I think behind that lie questions of efficiency, recognising that borders are not borders to ill health, and that there is fantastic opportunity, as Nick has talked about, in terms of learning. Now, when we're talking about what creates health, I have tried to divide into those kind of three broad categories, which will in different ways be familiar to you. It's the kind of the underlying determinant. So if you were living in a poor country, the very first things you need are food, clean water, shelter, and on you go. It goes into safety and freedom from being involved in war, having a decent income, and so on and so on. So gradually you build a picture of what actually impacts on population health. And then you think about, okay, so what are the lifestyle factors that impact? And there are many that we can go into, but I've written down a few for us to think about, the tobacco, the smoking, alcohol, sex and appropriate sex and appropriate prophylactics and so on. You then think about the screening and prevention. And I think what's particularly important in terms of healthcare is to think about appropriate, affordable and available access to healthcare which works. So I think there'll be a broad discussion, no doubt, today about some of those issues. We do recognise that globally we have a commonality of interest. Climate change. Is climate change going to impact on health? I think so. So therefore, it's part of what we need to be looking at. Infections across borders, we've talked about that several times already. We've talked about the open borders of the EU, and particularly the near neighbours and the common border, that is the emergence of diseases that we thought had gone away. And I think perhaps when we're talking about the economic crisis, we may find coming back again some of those diseases that are more associated with poverty. Then we think about things like the EU's role in terms of trade agreements, from agricultural policy to the degree to which it promotes still some subsidies, I believe, for tobacco, but certainly not sufficient promotion perhaps of vegetables and encouragement for sugar industry, etc., etc. So we can think about the implications of EU policies and how they impact on health. That's within the EU, I recognise, but we go more widely. And again, we think about why we're involved in Afghanistan and Iraq and global security threats from terrorism and so on, and the importance of having a global perspective. So I'm going to get to the point. The point is, what's action at the European level? Well, I have said that in my system, I'm sure many of your ideas of how health is created, actually tackling the underlying causes of ill health in lower income countries is priority number one, and therefore the EU, with its very large development budget, has a very large role to play in helping to address the MDGs. And I think therefore a good discussion around how those are renewed come 2015, and I would suggest have a stronger focus on the underlying causes of health, and particularly how that's spread across the population would be really useful. And so I want to see strong leadership from the European Union in how those new MDGs will be shaped. The second part is that, we've already indicated, agricultural policy, borders, health, research budgets, in many areas, security, many areas, the EU has a role. To what extent it takes the strategy adopted by the UK government in Health is Global, I think is really important. If we could have something akin to a global health impact assessment of policies, I think we can make a major difference to the impact that the EU has. No doubt there will be people in this audience who remember things, policies that have been undertaken by the EU, which have been detrimental to some lower income countries. An example is the banana trade, Windward Islands, and I think the market closed down for bananas from the Windward Islands coming into the EU, which had a detrimental impact on the Windward Islands. But that's a minor example. I'm sure there are many others we could go into. So thinking about the EU's own policies would be fundamental. Yes, I agree we need further funding for health research, and the caveat that I'm going to throw in is that we do appear to be heading towards a research budget whose primary focus is going to be what can Europe get from research? How do we sell our health elsewhere, rather than what can we do to support needed research in both the European context and more widely. I think we also have something to do to look at the harmful impacts of some of those health damaging industries. I particularly focus on tobacco, which is very obvious, but then you look at alcohol and you can think about how increasingly, particularly in Brazil and India, the market for alcohol is increasing, and that involves European companies and so on. So can we build a global alliance to think about how we address some of those basic NCDs, and you can throw in nutrition. I was intrigued also that, just as a little kind of reflection, we're involved in a piece of work at the moment, just a bid, and the bid is to map research within the EU on NCDs, non-communicable diseases. I found it interesting that it was framed as thinking about what happens purely within the EU context and not more globally. Can we not find a way of developing that so we're actually thinking about a global good of knowledge on what works in terms of research, rather than framing it purely in terms of the EU. The next point is in terms of system-wide approaches and discouraging a single-issue approach, which I think goes back to many of you will have seen in lower-income countries in particular, where funding goes to a particular disease or a particular focus, which is, again, can be detrimental to the overall health systems. and a little flag in there that says we've uncoupled aid in the past so that you don't have to buy a British, I was going to say British Land Rover, I'm not sure who owns Land Rover anymore, but you don't have to buy British if you're doing a development project. Similarly, if the best answers lie in neighbours from the south for a problem that resides in the south, can we not find ways of doing more south-south funding? So, I'm going to conclude with 8 points, and then the final practical points after that. It's really a reiteration. We should consider global health in all policies at EU level, push for stronger and better deliveries of MDGs, finance effective research, including on disease prevention, support NCD-related actions, particularly in terms of lifestyles, provide leadership in protecting us from health threats, and I think there's some very good leadership, and we'll hear more from the HPA, but also I'd be expected to hear more from the ECDC, European Centre for Disease Control, and how they can help to develop a global surveillance mechanism. I've already talked briefly about health system support and not for vertical programmes, and then a focus for accessibility, affordability and availability. And I finish with some practical, what really next? What could you actually ask the European Commission to do? And I actually was very impressed with their communication in 2010, but less impressed, by recognising the difficulties, with what has taken place since. I may not know enough, maybe that's part of the answer. If they could really resource and fund a global health team to manage this programme of work, I think that there is you can make a fundamental difference by taking into account a lot of the points that I've covered there. There is talk of a global, a programme of action on global health for 2013. It may be out, maybe I've missed it, but I couldn't find it when I went searching today, and I believe it's due. So that tells us something. I think we can also look at what's happened from UK governments, and it could work with his other colleagues in other member states and encourage them to take a similar approach, so that you then have a representative in the member states who can focus on their country's approach to global health. And maybe a very practical solution is to actually work towards what's called joint action on global health. So it's a bit of financing from the Commission to governments, member states, to actually take work on global health forward at European level. I have focused on Europe, I have done what I've said, and I have taken more than 8 minutes, I apologise.
Thanks very much, Chris. They're very helpful thoughts. We've got about 45 minutes or so for discussion. I mean, maybe just in order of appearance, as it were, let me just start with Nick. Actually, coming back to, I thought, one of Chris's interesting points, the kind of, not just what, as it were, Europe could do for good, but what Europe could do less of for bad, as it were. I think flipping the argument. I mean, first of all, it's good, obviously, hearing from the Department of Health and not just DFID, for example, within the UK in terms of contributions to global health. And you mentioned the positive aspects of volunteering and partnership and so on, but flipping the coin, of course, the brain drain for a second. Now, clearly, there's the global context of the slowdown that's maybe reduced a little bit demand, not to mention austerity measures and so on domestically. And obviously the NHS, like some other countries, has introduced these ethical codes. But do you think we still need to go further in the UK and elsewhere in Europe, since that's our geographical focus, in terms of actually trying to prevent, as it were, this inward movement? Because I mean, even on the, just to anticipate and push on the ethical guidelines, there's no doubt they've had some effect in stopping a direct transfer from Zimbabwe into the NHS. But we all know, of course, it's only 2 steps removed from going into a private nursing agency, working a few months, and then transferring across, for example. So do you think there's more you and your counterparts elsewhere in Europe need to and could do to try and develop indigenous resource and not encourage that further brain drain?
Absolutely, and one of the fundamental principles with workforce planning in the UK is that we do have a sustainable workforce. Whilst in the past we've recruited a number of doctors from other countries, we are now in a position where we're no longer reliant on doctors from other countries. It's still clearly a challenge in Europe, not least look at countries like Romania, where when they joined the EU, suddenly their radiographers up to move to Germany because they were going to get paid an awful lot more in Germany. So there is no easy solution to this. It's one of the things that, one of the important reasons why the WHO Code of Practice would agree to try and address this. If we turn that back around the other way, though, there is equally a role for the UK, and I'm sure other member states as well, to provide help in training doctors and nurses in other countries. So some of that we're doing on a commercial basis for looking to for some of the Gulf states. We're also looking at the opportunities for doing that in China, Libya as well. So it's certainly, I think, going to be an ongoing challenge, but ultimately the solution is to ensure that all countries have a sufficiently large trained workforce and they're able to actually retain them in that country. It's really a part of the work is some of the expertise that we've developed in planning, in looking forward 20 years or so, what are the workforce needs that we're going to have in the UK in 20 years' time, and how can we then ensure we have enough training places to meet that, but then sharing that planning expertise with other countries so they're equally in a position to do that.
Okay, and maybe just keeping on the human resource theme for a second, maybe Beatrice, from your perspective, of course, because the other aspect of the brain drain is what you see very often, of course, is, as it were, an internal brain drain, isn't it? You know, I think in many, particularly African countries, where people have gone out of the government healthcare system and they haven't necessarily emigrated, but they've hopped over to an NGO, dare I say it, very often funded by philanthropic or private organisations with, you know, very often very specific vertical targets, and of course, you know, very often quite short-term objectives, 2 to 3 years' time, and the possibility to pay a lot more than the public sector. And so you do see quite often, I've observed it very often, you know, that internal destabilisation. Of course, once they've left, they're very unlikely to go back. I mean, any thoughts again, what funders, public and private, are doing or need more to do in that area to try to support, you know, the indigenous, as it were, mainstream health system, whether publicly funded or funded through social insurance or whatever?
Yes, so I think that's a great question. First, I have 2 or 3 thoughts. The first one is, while we see natural brain drain, because there is the attraction of just the resources, the revenue that inequality that attracts them. Similarly, we also see a lot of, for example, taking from the foundation side, foundation staff that then, after having been with the foundation, sort of thinking, I don't bear to be in Seattle for another month, and actually go and just work in those institutions in Africa. So there is also that, but wider than that, I think, as we've realized that, again, speaking from a foundation's perspective, that challenge, we've also diversified the way we partner in Africa, and so in African countries. So it's not just with NGOs now, it's also directly with governments. For example, the Agricultural Transformation Agency in Ethiopia, which is really building an institution within the government and helping to bring capacity for, again, that's a characteristic of the foundation, because the endowment is not going to be done in 2 or 3 years. We can actually have a long-term view, much longer than sometimes that some budget cycles that donor governments have to just be constrained by. So I think there is an acknowledgement that we need a longer-term approach, and that's why, in a way, the EU, with its 7 years budget, is in a unique position to be able to program over a longer-term time period. The diversification of partnerships enable us to not just, in an asymmetrical way, just fund NGOs in such a big way that then other sectors would be affected. And I think that's something, that's a trend that's shifting for us at least. And then finally, on the vertical versus wider sectors, I think if you look at again, speaking from a foundation perspective, if you look at the number of areas in which we operate, I think while we want to be very We want to bring the very best and the very finest of analytics and products and technology in particular areas. We do span over a fairly large amount of priorities, which in a sense brings a variety of interventions to those sectors. Very much aware of the fact that we need to have an integrated approach, and actually it's one of the things that while we're trying to think through what are better ways to think through product development with integrated development and thinking through, should you build actually a common platform between HIV and TB research that would build on each other and find synergies there at the delivery mechanism. There is actually now more of an integrated delivery team with the foundation that thinks through those interventions in a more holistic way. So I think, as you were saying, we're, again, from a foundation perspective, we're quite young, progressing, and I think that we've seen that trend go to other actors, so not to be all positive and rosy thinking, but I do think that there is a good perspective forward for that.
Okay, thanks. And Chris, you raised those issues. I mean, on the subject then, so as it were, do no or do less harm first, and then we'll talk about some other more positive things. But you talked about some interesting issues around some of the areas where Europe could be changing its policies. You might have some views on the brain trade issue, but I was going to do, what you didn't touch on so much was, for example, trade, and I'm thinking, for example, about intellectual property, pricing, and even regulation, actually, for example, in drugs, where there are, for example, drugs that are manufactured under Europe's high-quality reputation but haven't been and wouldn't be approved by regulators for use in patients and yet get exported to other parts of the world. I don't know whether you've got any thoughts on some of those areas where there could be more coherent policy.
The quick answer is no, actually.
Okay.
Thank you for asking that question. I wouldn't dream of speaking in an area where I don't feel that I have the knowledge. There's nothing we just fly break in the air. So I'd be more interested in hearing what others have to say, because I think that is a fascinating question. The bits I was talking about, and I do recognise the complexities that were behind, were in things like tobacco. And I've just recently put together an EU-US civil society dialogue on, it's actually on alcohol control. And it's intriguing to when you begin to unpick what's happening in some of the emerging economies and in some low-income countries, how little funding actually goes towards alcohol control and the implication that has in terms of the impact on the population. I believe that there's a risk factor from global burden of disease. Alcohol sits in the level 3 in the WHO analysis, and yet what is there in terms of say, DFID funding or DG development funding that will support those people who are trying to make sure that the harms caused by that product are reduced. Of course, you then recognise it's a market, so how do you set against the market against the harm? I recognise there are complexities that need to be dealt with within that, but I don't think the balance is right yet, is what I'm saying. So I'm afraid I'll have to leave your intellectual property rights question to those who know more than I.
But it's true, I was just looking at cancer in Africa, for example. So, I mean, the global burden of lung cancer is about 1.4 million deaths a year out of about 7.5 total million cancer deaths. Enormous burden, and of course, huge growth in the development world. I mean, is there any traction, even, or kind of initiatives going anywhere within and across Europe that precisely might, try to impose global brakes, perhaps, on the export of some of these rather unhealthy things that, as you say, the drivers of non-communicable disease in the developing world?
Well, again, there will be other people who can answer that particular one in more detail, but for me, I think the Framework Convention on Tobacco Control has put down a very good marker and shows a way forward for what kind of breaks you might have. I think it's very hard to actually, I do not know what brakes you could actually put on industries located within Europe to stop selling inappropriately, and you might argue what's appropriate, what's inappropriate in terms of tobacco in lower-income countries. I think that's harder, but I think actually putting in place or supporting the development of national strategies to tackle tobacco control, to tackle the harmful effects of alcohol, and also to consider increasingly the impacts of a refined diet and its implications for nutrition. So all of those we could think more about, but perhaps it's also partly about getting our own houses in order as well.
No, I just tried, but I think it's a really interesting area that, that I mentioned it in the context of drugs that are manufactured, with the European quality export. But I mean, even in terms of, we wouldn't allow lead or various carcinogens to be put into food or certain, toys, for example, manufactured in Europe for global export, as it were. Perhaps there is a case to do more, to think more broadly on that agenda of what applies within Europe should also apply to anything manufactured, based or regulated within Europe for global activities. Would anyone else like to comment on those doing less harm?
But in effect, that is already written into EU legislation. If you look at the food area, for example, there's already requirements you can't export products outside the EU that aren't considered safe for consumption in the EU. In terms of pharmaceutical products, actually, it's interesting you talk about products produced in the EU. Actually, the way the global market is shifting, it's more us sourcing products from outside the EU into the EU. So China and India are big manufacturers now of pharmaceutical active ingredients. But equally, when you talk to people from health industries in developing countries, it's not so much the branded products they're interested in, it's the generic products, more often than not, that are produced at a local level and may or may not be subject to the same quality control criteria we're used to in Europe. On NCDs, I think there are a lot of action that could be taken, but the one thing I've seen over the last few years since I've been involved in this, there is no one single solution. You can't simply stop the sale of tobacco and that will cure everything. You can't stop high-fat foods and cure obesity. It needs to be looked at a whole society approach. And as Chris was saying, if many of the social determinants are really the keys to unlocking a lot of this, coupled with a lot of activity around prevention rather than treating the symptoms.
Yeah, no, not much to add to this. I think that there are within the tobacco question. I think what I know from the foundation's work is exactly what you were saying, which is really focusing on the prevention aspect and the policy aspect in countries, and that already is something that is hitting a lot of the very strong tobacco lobbies. In terms of IP, tier pricing, and norms, I think that there is absolutely no question that it should be the same norm everywhere, and I think that one of the things that we're actually even trying to, again, that's creating a market for something that works even more is different strands of diseases change based on medication, and being able to even develop products that will really respond to the strains that are specific to tropical areas versus just the ones that are in Europe, and India still working very strongly with India manufacturer to be able to reduce the price heavily while keeping a very high standard is absolutely a non-question.
And let's say, before we open it up, maybe just one last thing. Let's just talk more generally on the context of post-2008 and the crisis and the funding issue and how to respond. It was ironic, as you were saying, Nick, I mean, there were these great series of reports and strategies. 2008, a pretty ill-fated year to launch anything, unfortunately. I mean, I wonder what your impressions have been since then about how far the momentum around some of those strategies has fallen by the wayside, or how far there's at least the potential, maybe in some way, to sort of capitalise on that crisis and re-evaluation in a way that could benefit in a cross-border and international global health. Well, that's interesting to start.
I mean, yes, in the work we're doing, we've seen actually almost that it's a very American thing to do for a French person to say there is a crisis that's an opportunity. So we've actually seen in the development strategies very strong focus on high impact mechanisms, evaluations, and things that will really make every investment much smarter. I think the key question with that is how to do it without, again, cannibalizing the more holistic approach that needs to be taken, and think through the growth aspect of that, and linking those highly impact intervention to targeting that very sort of niche area where bringing aid to these really catalytic interventions where you're going to be able to get out of the poverty trap, and then being able to link it to private investors so that they can then take it forward in a sustainable way. And trying to link those things almost in a market, a value chain aspect, almost in an industry way, sometimes works, sometimes doesn't for them. I mean, you have to be careful. But it's really something that we've seen across governments with whom we're talking to on a regular basis really emerge on be it for health or agriculture.
What do you think, Nick? When you talk to your counterparts across Europe, do you see any, there's sort of a restructuring, but also a potential for some sort of refocused, continued or growing momentum?
Inevitably, health budgets across Europe and further afield are being squeezed, and there are really two ways that countries are then looking at that. One of them is looking at the pharmaceutical budget, and is there scope for reducing that, particularly with a greater shift to generics, for example. The other is looking at the health systems themselves and whether those can be made more efficient. And I'm not sure necessarily that all member states have really taken that as far yet as they could do. But as Beatrice was saying, there are actually some real opportunities from this. I think John mentioned earlier about innovation and being an important component of this. And actually, if you look around the world, where are some of the really innovative countries in terms of healthcare? They're not in Europe necessarily. There's clearly innovation there, but if you look at India, their use of mobile phone technology linked to health is probably state of the art in many ways. Their heart surgery, if you go to Devi Shetty's hospital in Bangalore, they have facilities there that are probably as good, if not better than the UK, doing operations at a fraction of the cost of the UK operations. So it is really an opportunity for everybody to look at how can we learn from each other and apply the best experience wherever it happens to be, whether it's in a remote country in Africa, whether it's in the US or elsewhere in Europe.
And you see, and you talk particularly about kind of the tensions within Europe, but again, in terms of, for example, some of these extra volunteering programs or broader global health solidarity, has that been largely a victim, or even there have you seen some? It's great to see the feeding in theory, or hopefully into Europe, of innovation from externally. What about the export of initiatives?
If you take the UK context, actually the budget for that activity has increased under the current government. There's a £5 million set aside for the partnership scheme, which is a significant increase on the funding under the link scheme. So certainly at the UK level, I don't think it's true to say that there's been affected. There was a conscious decision by the government to increase the aid budget rather than reduce it. I can't say that's necessarily the case in other countries, which are clearly suffering considerably more, and wait to hear what Spain's going to be announcing today, but I suspect there'll be further cuts, for example, in their health budget.
Chris?
Yeah, my penny's worth on this one is that I do think that actually that within the European context, far more of the future programmes seem to be saying, what can we do to make Europe economically competitive? It's obviously desirable, but it takes out some of that, and what can we do to work effectively globally? And I come back to what I said previously about, I think the research budget is really saying, how do we get pharmaceutical technologies into the marketplace as rapidly as possible? I think that's a kind of the driving force at work now. When I look at the health budget, a lot of it is now increasingly about cost containment. rather than supporting a kind of a well-being agenda. I think to some extent, though it's not true in the UK, that some of the health inequalities agenda is actually diminishing. It's harder to talk about than it used to be. So there are those countervailing pressures. The flip side is, you might say that there is more of a, maybe it is a global movement, the Occupy movement, the recognition that inequalities do exist, and perhaps there is more to life than the bald economy, to take a bigger view. Whether anything will change or not, your guess is as good as mine. So I think that something lies in there. I think that there will be that drive for greater efficiency, which actually does demand that we spend more time doing that international lesson learning. So it struck me as that we do less than I'd expect if we're developing an obesity strategy. How do we really systematically go around looking at what has been effective elsewhere? I think we have been playing with that in part, I don't want to knock it too far, but I think there is a lot more that we can do to establish a mechanism for international learning in whatever dilemma, problem, opportunity we're trying to address. So there's something in there. Perhaps the last little tiny reflection is about the possibilities of looking at the kind of the nice cost containment model within the European context. I'd be surprised if there isn't the emergence of something like an international nice, in a more formal way, largely as a mechanism for cost containment across Europe, and perhaps that also then rolls out to other countries as well.
Well, there's certainly equivalents being looked at in China and Brazil and a number of other emerging markets, I'm sure. Yes. Okay, let's open it up. Who might have a reaction, question, remark, please? Want to come back in?
Andrew,
Yes.
I'll lead off. Time is